We're going to try and start on time tonight. So it's about now. You're welcome to. No one's going to take away the food, so you're welcome to help yourselves to a cuppa and a bit more of a snack at the end. Welcome everyone to the Elkington Oration for 2019. My name is Letitia Delfabro and I'm currently President of the Public Health Association Queensland branch. I'd like to welcome Gaga, Kerry, Charlton for Welcome to Country.
Thank you, Letitia. And thank you for having me here to do Welcome to Country this evening too. And it is always an honour and privilege to do the Welcome to Country on country and to be able to do it because we're still, all of us across the nation are still putting together parts of our stories. And through my mother's father, we are Yagara people and we're Gurunful people. And Gurunful is one of the groups of Quandamooka. So it is in the, how embarrassing, eh? Doesn't it help with that? Or him, not me. I probably embarrassed him more. But, so we're one of the groups in the Quandamooka peoples. And we're also part of the Yagara Ugarapul claim that's currently in the National Native Title Tribunal. And we're also Kabi Kabi. So we're part of Kabi Kabi as well. And the little gap in the middle for political reasons we would be claiming it, but there's a bit more work to undo some historical political problems. But so we kind of come up from the east, the back beach of Stradbroke Island, where we are traditional to this area. It is actually Gurunful country from Oxley through to the mouth of the Brisbane River. And then we jump over and go west. And that's through two grandparents, Charlie Mookin and Maminda Daisy Thompson. They are the two great-grandparents who our Yagara, bring in our closest Yagara connection. If I go back another 3 or 4 generations, I can give you the names right back to about the time that of European arrival here. That's the extent of the knowledge that was given to us by our old people and maintained, but also we've had to do a lot of research and fact-finding missions as well. And but that locates me here, and I want to also acknowledge other Guris here tonight. We say Guris, that's our lingo, or Aboriginal people in this area. And I know Kabi Kabi people say it, and down to Bunjalung, right through Bunjalung country. And so it's a word which really just means black, really, Guri Gurun. And it's just the way that it's used. So I have a grandnephew who's called Gurun Yukil, or Black Bandicoot. And so we had lots of fun remembering how to say his name, especially when they're running fast past you and you're trying to do 3 language words that are, And then of course, then they call the next one Kuruwiana, so that was like and cookie, so we shortened it to cookie. So, we have lots of fun in our retrieval of language and our culture. And of course, there's a lot of pain, but it's strengthening us as well as we take each step by step. In our kinship system, we are the Jandare clan, and Jandare and Jandaroo, sometimes it's heard of, is ironbark tree, and that's also part of our economic system as well as our cultural and kinship system. So in our kinship system, we were our clan group or family groupings were took after the names of the flora. And then the totem system, our Yuri system, took the animals. And so that's why we have such strong and deep relationships with the land, the animals, our trees, everything. And of course, with that comes our healing, very much so. So I just wanted to share that with you to introduce myself and also to acknowledge our ancient neighbours, Gubbi Gubbi people, Waka Waka people, Jinnaburra people, Waka Waka people, and Yugambeh and Bundjalung and the Quandamooka peoples. And my family were very strong about that because my great-grandfather was a message stick bearer and was very strong about us observing our protocols and our laws. And so through those connections, there were old people, well, they were young probably by the time they were rounded up and put on the missions from Durrida Station up to Deben Creek, Perga, which became Perga, Baramba, which became Cherbourg, some sent to Woorvinda, later some sent to Palm, and then many brought down from other areas. And my grandmother's mother was brought down from Gulf Country, from Wollongama tribal people's land. So we have all of these stories and connections, be they historical or traditional and contemporary, to this country, this Yagara country. So as I look out, I can see all the contemporary arrivals. So, but I want to acknowledge countrymen and countrywomen I can see here this evening, acknowledge the elders past, present and emerging, and I would like to say Nariba Bing, Munya Waganiba, Niba Ni Marumba, Nyuru Niba, Nyuronya, Dagu Bayan, Marugunya, Yagan, Yagarajara, Bibalka, Yangali. All of you here this evening, while you're on Yagara country, be safe, be well, as we work and as we talk and as we be together. Be blessed and be safe. Bibalka, Bibalka. Welcome, welcome. Thank you.
Thank you so much. That was really moving. And we've just got a small token of appreciation for you.
Oh, thank you.
Yeah, so thank you for your time. I'm not sure. Do we know what the type is of peace lily?
Peace lily, yeah.
Nice, thank you.
So I'd also like to acknowledge the generosity of the Cancer Council Queensland for giving this lovely venue for us to hold the oration this evening. And I'd like to acknowledge our three sponsors for the evening. So the University of Queensland School of Public Health, Menzies School of Health Research, and the First Peoples Health Unit at Griffith University all contributed to help us pay for catering and get the night underway. So just in terms of the Public Health Association, for those of you who aren't members, the Public Health Association of Australia is recognised as the principal non-government organisation for public health in Australia and works to promote health and wellbeing for all Australians. We seek to improve population health and health outcomes based on prevention and social determinants of health, and also based on equity principles. The Queensland branch, we hold professional development events, and the last few years we've had careers events, for example, mainly for new graduates and early career public health practitioners. Yes, so we welcome you to come and join us at a Queensland branch level, and you can follow us on Twitter as well. So I'm going to hand over now to Paige Preston, who will introduce the oration this evening.
Thank you, Letitia. So tonight I will be welcoming Professor Bronwyn Fredericks to deliver the 2019 Elkington Oration. Before I do introduce Professor Bronwyn, I would like to first share the origins of today's event. So Dr. Jack Elkington was an Australian physician with a distinguished career in public health during the early part of the 20th century. He was born in Castlemaine in 1871 and enrolled in medicine at Melbourne University, and despite failing some of his final exams, gained qualifications in medicine and surgery in Edinburgh and London. So he worked as a GP in Geelong before completing a diploma of public health at the University College London and a doctorate in medicine from Brussels. He was Chief Medical Officer in Victoria for 6 years before moving to Queensland in 1910 to take up the role as Commissioner for Public Health, during which time he helped frame the 1911 Health Act Amendment Act, which substantially expanded the scope of the Health Act, extending its public health focus. He was also involved in responding to outbreaks of plague, smallpox, and also developed programs in areas such as sanitation, food hygiene, and child health. He then, when his and others' advocacy efforts had been unified, he unified the Commonwealth approach to quarantine, which was successful, and he moved to the newly formed Commonwealth Office of Quarantine as first as Director for Queensland and subsequently for Northern Australia. He advocated a national focus on tropical health in Australia and the islands and territories to the north, raising concerns for the well-being of the people who lived there and the possibility of introduction of infectious diseases. After an illustrious career, he retired in 1928, aged 57, and Dr. Jack Elkington died in 1955, but a few years later, when a group of health professionals formed the Queensland Society of Health, the inaugural committee incorporated an oration to honour Jack Elkington into its annual general meetings, and the first oration was delivered in 1958. The Elkington Oration has survived the Queensland Societies of Health's incorporation with the Australian and New Zealand Society for Epidemiology and Research in Community Health, and the formation of the Public Health Association of Australia. And we aim to hold the oration every 2 years to honour the work of Elkington in public health. So in keeping of the spirit of the Elkington Oration, it's now my pleasure to honour the work of another distinguished leader in this field. So Professor Bronwyn Fredericks. Professor Bronwyn Fredericks is the Professor and Pro-Vice Chancellor, Indigenous Engagement at the University of Queensland. She undertook training and education in the disciplines of education and health at Queensland University of Technology, University of Tasmania, and the Central Queensland University, along with undertaking an NHMRC postdoctoral program at Monash University. Professor Fredericks has also been the recipient of both the NHMRC and Endeavour Awards for her collaborative work with others, and has been awarded grants for NHMRC, ARC, the Australian Institute of Aboriginal and Torres Strait Islander Studies, Diabetes Queensland, and the Institute of Health and Biomedical Innovation. She has held positions with both the Queensland and Commonwealth Health, along with universities, including as President of Academic Board and CQ University. Dr. Bronwyn Fredericks has also worked with community-controlled Aboriginal and Torres Strait Island organisations for over 35 years, including as volunteer, board director and staff member, and has a history of engagement with Indigenous communities in Queensland, Australia and internationally. Bronwyn is a member of the Australian Institute of Aboriginal and Torres Strait Islander Studies Research Advisory Committee, the Beyond Blue National Research Advisory Committee, and a member of the Australian Research Council's College of Experts. In 2016, she was appointed as one of 2 commissioners with the Queensland Productivity Commission and was the presiding commissioner for the inquiry into service provision in discrete and remote Indigenous communities. She is presently working on the inquiry into imprisonment and recidivism. Ladies and gentlemen, would you please welcome Dr. Bronwyn Fredericks as she delivers today's Elkington Oration entitled Working Together Towards the Change and Transformation Needed in Indigenous Health.
Here, when I talk off that, yeah.
good evening, everybody. Just say I get a bit scared when I hear that myself. I want to begin this evening by thanking you, Gudger Kerry, for your welcome to country to everybody. And it's always a pleasure to hear that, but to centre us in terms of what we need to be centred within and on in terms of the formal process of beginning and our discussions in the evening. I do want to acknowledge other Aboriginal and Torres Strait people that are here this evening, and also non-Indigenous people that have come along to hear what I've got to say. For me, going forward, a lot of what we have to say as Aboriginal and Torres Strait people rests on non-Indigenous people to talk with each other about where we need to go and what we need to do. Because as you'll see and hear from me tonight, Aboriginal and Torres Strait people have been saying some things for a long time, on deaf ears sometimes. And we're going to keep saying it, but we just got to get on and keep doing our work, and you have to do your work, which also includes talking to one another. And you'll hear me talk about that often this evening. Where does this aim to? Got batteries?
Hopefully.
Got a technology issue. So while they're getting that organised, you've got something on your chair. I just wanted to put that up. That's our latest artwork at University of Queensland, and I've got to give that a plug in terms of the sponsors this evening, in terms of being University of Queensland, First People's Health Unit, Griffith and Menzies. That's the artwork that we had two wonderful women, Quandamooka women, design that work for UQ, which will underpin and underwrite our work. And normally I don't talk too much about artwork because I think there's enough Indigenous artwork across Australia now that people use on uniforms and everything else. We need to start implementing what's in the artwork to do the work. For us at UQ, this will be the last major piece of art unless people donate it or unless it's a public art that questions colonisation in terms going forward. But that is our major last acquisition. In terms of what I've given you, and I don't want those Koori mob in the audience to share with other people what this is. What is it? You can't say either, Charles. You were at another talk. It's a bunyana, okay? And I'm going to base today's presentation, Elkington Oration, around this today. So I want you to hold this bunyana as I talk, and in some ways think about my words. And I'm going to connect it to the bunyana, but you are going to connect it as well through my words. And you're going to take your bunyana home with you tonight. And you're going to be able to reflect on that as we go forward in the future. And I'll talk about why. Now, for people who don't know, this bunyana comes off and out of these shells here, which then those little shells are contained in this outer casing, which are in that big nut at the top. They get to be 10 to 15 kilos. Huge, right? Huge. If one of those falls on your head, bang. Talk about a public health nightmare, right? When there's lots of the trees. Okay? So it is. But that tree, as it looks over here, anyone know how old they can become? Older. No, not 1,000. About 500 to 600 years old they can become. My family, in terms of my partner family and grandchildren, we were really upset because in the cyclone Marcia, we actually lost the only bunya tree that was in the Botanic Gardens in Rockhampton. It came down, it was over 100 years old. It was quite upsetting for community to know that that came down. The trees can become 500 to 600 years old. You just think about that. The trees mostly grow in southeast Queensland up to some parts of northern New South Wales, up to about Miriam Vale's probably the last time you'll see them. If they're further north, it's because someone's taken it there, or taken that one tree or the couple trees. If you think about them being along the coast and the gatherings that used to happen, these trees only produce these nuts every 3 to 4 years. There'd be great gatherings of people of all the clans and all the nations around that would come together to make agreements, that would come and look at what they'd done from last time they met to this time they were meeting. There would be marriage laws, there would be games, there would be feasting. There would be a whole lot of things that would happen around that. People also knew what it gave. This is a nut that currently the university is working on in terms of producing possible baby food. It is that good in terms of protein, but also digestible food. Yeah? You can eat this, cook it, you can replace it instead of tofu or meat. There's a lot of properties held in this tiny little nut. I also want to say that with this tree, there's only this tree and 2 other trees that date back to the time of the dinosaurs in Australia. Okay. This, the Wallamai pine and the hoop pine. So in terms of collections of trees, and they produce all at the same time, they're always together, there are mobber trees, okay? There are mobber trees who get together and kind of hang out and then produce every 3 to 4 years. They've witnessed a lot of things, and if you think about it, they witnessed Cook. The ones that are alive today could have witnessed Cook going up the east coast. They witnessed the massacres. They witnessed the coming of white people. They witnessed the disappearing of Aboriginal people from big gatherings. They witnessed so much. Okay? They witnessed so much. Doesn't mean it's lost from memory. I want you to keep those stories because I'm going to keep referring back to the story of the bunya nut and those stories through my presentation. So I'm going to talk about the what is, what has improved that we know, what hasn't happened, what works, and also what needs to happen. What needs to happen. And think about that in terms of the bunya trees and what they have witnessed and what they're still witnessing today. What have they witnessed? What do they still witness? And what will they continue to witness going forward? Because they're still going to exist. And that's the point I want to make. They've been here since the dinosaur times. They're still here. They're going to keep being here. Okay? They're going to keep being here. They're going to keep witnessing us as humans, as human entities, on the planet within this region and going into North Queensland or Central Queensland. So I want you to think about how they witness you as well, all of you. We know that in terms of life expectancy, these are the statistics, and I'm not going to keep reading all the stuff out that I'm going to put up because I want to get to some of the juicy bits as what does work and what needs to happen. But you just have a look at those statistics of what is. In 2019, we are still seeing these kinds of statistics. I was reading some of these statistics when I was in my 20s, just starting out at university. And I'm sure some of you were reading these statistics when some of you started out at college or university or started working in health. All right? I bet you did. I bet you saw these, Francis, when you started out your time. And you saw him as a nurse. I bet you did too, Amanda Lee. Saw these statistics. I bet you did, Tracy, when you were looking at things. And I'm sure other people did too. We look at the social determination, the social determinants of health. We do see housing, despite the National Housing Program, the State Housing Program, housing is a major issue. The work that I've just undertaken with the Queensland Productivity Commission, going to remote and discrete communities in this state. We produced that report in 2017. It was handed to the Treasurer. We still see those recommendations not implemented, and we still see the same kind of data this day and age, 2019, that we would have seen years ago. Sure, there's been a little bit of improvements, and I'll show you those in a minute, but they're not significant. In no way significant. It's really depressing when I was undertaking the review into discrete and remote communities and still seeing 15 to 20 people in houses. And we talk about, and we're here at the Elkington Oration, looking at public health, you know, and I'm a member of the PHA. I hear people talking about this stuff. We still haven't shifted some of the goalposts around this to even make significant changes. So we've got to ask ourselves, what are we doing? What are these bunya nut trees? What are the bunyas watching us do? How do we carry out our work as we transverse across the country? In terms of education, we do see some gains, and I'll show you this in a moment. Just let you read that. And I'm very privileged now to be at UQ compared to where I've been at CQU and QUT and Monash, because I can tell you we have some of the most amazing, deadly Aboriginal Torres Strait Islander students in the state studying at UQ. We have students there, and it doesn't show in the data. We have Aboriginal Torres Strait Islander students there with OPs of 1, OPs of 3, and that's what the data doesn't show. It's the same as when we look at the bunyana. You know, it is a form of excellence in a sense. Everything from a baby food through to old people can eat this and still digest it. It's sustained from the time of the dinosaurs. Can live to be 600 years old. It's a form of excellence. Some of our young people are the epitome of excellence in education, but they're also excellent at a whole lot of other stuff, not just education. What has improved? I wanted to put this up because some of the improvements we have had are a result of people like some of you. And that's unmistakable. And so I wanted to acknowledge that tonight. Some of the gains we've had are because of public health. They are because of things like immunisation. They are because of things that have happened around maternal and child health and the broader public health interventions that happen. And I'm not going to go into all of those things in terms of an operational sense, but you would know what some of them would be. We know that that gap is starting to reduce in terms of males and females. Starting to, a little bit. But you know what? It is for non-Indigenous too. So in a sense, we've got to be careful when we look at some of the data, because we can't just look at it in terms of Indigenous data alone. We have to look where is it being matched with non-Indigenous data, and the gains made by us as Aboriginal Torres Strait Islander people are also gains made by non-Indigenous people, and therefore there's a bigger population impact here, not just relating to Aboriginal people. And if I pull up the data on where Sid is there, the cold communities, you would see similar. You would see some of the poor cold communities or vulnerable refugee families. Some of the data is starting to mirror in them, those communities as well. In terms of where there was discrepancy and marginalisation and vulnerability, there's been some improvements as well. So they're bigger, broader public health improvements. And the smoking rates. We're here in the Cancer Council. I see don't smoke signs everywhere. There's some in the car park there or in the building. You know, in terms of smoking rates, we've made, and I'll say we, because I've been part of that at some point as well when I was working with VACHO. There's been huge gains made in trying to get people to decrease their smoking or quit smoking. Still a lot of work to happen. Still a lot of work to keep going. We're nowhere near compared with the work that's happened in New Zealand in terms of the gains they've made. In terms of what has improved, home ownership is starting to be improved. And part of that is, yes, there's programs. Part of it is also because Aboriginal and Torres Strait Islander people are now also able to get loans. Because, hey, I work. Gudger Kerry works. Francis works. Other mob here, Tracy works. Trace works. There's other people here. Not just going to pick on those same ones. So watch out. But there's people here who work. We get loans now, you know. We're starting to get that where we participate in the economy. okay, in terms of the broader. Doesn't mean that we lose our Aboriginality in the process. Just means we're participating in the broader economy to change some of those things that are impact factors or that are measured in terms of public health. So please don't forget that. Okay. Homelessness has started to decrease, despite what people would think in terms of the profiling of Indigenous people in terms of homelessness. The broader statistic says that actually Indigenous homelessness in some ways has decreased in part. What has happened is there's been a shift in where the homelessness where people who are homeless are. Okay? So sometimes it looks like there are more in certain areas than other areas. You need to be very clear when you look at that and when you understand the data. Overcrowding, as I said, when I have visited communities, there's still significant overcrowding, but in terms of the data, it shows a decrease. But I'm not deluded to think that we've solved the issue, and when I say we, all of us, plus the government and community organisations, because it's still a major issue. It's still a major issue with housing, and the housing stock that it is in some communities is quite old. It's quite old, and takes quite a long time to get repairs done to some of that housing, in terms of sewerage issues, water issues, problems with even hinges, toilets, all those sort of things. Education, in terms of education, Queensland's a real star. We are having huge gains in terms of Queensland, in terms of our outcomes around participation of Aboriginal and Torres Strait people in education in this state. Other states are now looking at this state in terms of the gains we've made. Bit different to 20 years ago when we all had those eyes and binoculars looking for South Australia, because they were one of the shining states in terms of what was happening around Indigenous education, or Victoria. Now, in terms of secondary schooling and primary schooling, we are pushing it up in terms of participation rates. And that's really about changes to policy. That's really about changes to what's happening in schools. It is not linked, and I will question and debate with anyone who wants to debate with me that is lobbied and directly connected to people being charged for truancy. Because the statistics showed increases in participation well in front of any of those measures that were put in place about people where police were chasing up people for not going to school. That's a belated thing. What hasn't improved, I'll just put that there, and this is one of the things we need to be careful around the comparisons, as I've said, between Indigenous and non-Indigenous data, because some of these things are about all data and the increases or changes to all data. And so for people who work in public health, I advocate and I question you, challenge you to go right to that data and have a look. Yes, this is Indigenous data, but how does the data present for non-Indigenous people too? Is it just for Aboriginal and Torres Strait people, or is it for all people? Don't make that assumption, because there could be gains made across, and just riding on there's gains made for us doesn't actually support a bigger argument around Indigenous advancement in the area of health and public health. Does that make sense to everyone? It actually hides figures and hides the truth of the data. Hides the rawness of the data, like hides what happens with the bunion up. Imprisonment rate. Who saw the press today from the Courier Mail? What's Jackie Trad going to announce tomorrow?
Big prison.
Hey?
Big prison.
Big prison.
1,000 beds.
Hey?
1,000 beds.
Another 1,000 beds coming into Queensland. Who's going to occupy most of those beds in this state? Trace? Professor? Mob. Aboriginal and Torres Strait people. For us, imprisonment rates are on the rise and have been for some time. There's real issues around Aboriginal and Torres Strait Islander incarceration rates, and then all the issues that are attached to with that around health and wellbeing, in terms of people coming in and out of prison, back and forward out of prison, in and out of prison, and whatever people are in there for. So some of the work I'm currently doing at the moment with the Productivity Commission is looking at imprisonment and recidivism. So we are currently looking at the ways that people are charged, how people are charged, how people end up in prison for things like non-payment of fines, parking fines, not coming for their community service, and other kinds of issues around that end up in prison. And then that has a whole cycle, and we do know, and the data will tell us, evidence is there, that once you're in this cycle, your health deteriorates. I met a guy in Cairns 6 weeks ago, been in Lotus Glen prison for over 10 years, never seen a dentist once. Not once. Only time he'd seen a medical practitioner was when he had chronic pain. So you can think about that from a broader health perspective. When the prisons are overcrowded, even trying to get some support in being incarcerated is really hard in terms of one's health and well-being. I'm not putting this up here to shock people, I'm putting up here to say this is a reality currently. Now, when we want to talk about public health and well-being, also think about, and I use Fran Boehm a lot in terms of her, you remember that book, The New Public Health? It's not that new anymore. But if you're not focusing on Indigenous health, what the heck are you doing? Really? What really are people doing when we look at these statistics? What are people doing? What does work? So just like this bunya nut, we know this can fall on the ground. This could grow into a tree. Big tree that could live to be 600 years. How does it even know it's going to be a great tree? How does this nut even know it could be a great tree? How do Aboriginal and Torres Strait people know what works? How do some non-Indigenous people know what works? It's because some of this stuff has been tried. Some of this stuff is being evaluated. Some of this stuff has been researched. Some of this stuff has been written about. Some of this stuff has been clinical trial. Some of this stuff has been done for that long, you can't have a 40-year pilot anymore. Anyone here works with health workers who's still on short-term contracts after 40 years? Teacher aides, 40 years, still on casual 1 year to 1 year contracts because they don't know if they've got the money, but hey, they've got to be doing something right because we've still got them after 40 years. Come out of a Whitlam initiative. Tells you, 40 years. Okay? Long time. So we know what works. So the things that work, a bottom-up approach. Public health, you knew that anyway. Some of this stuff is going to be what you already knew. It's going to be what you already do. It's about reaffirming and reasserting the same way the tree keeps coming and has lived since the dinosaurs. It does what it knows it's got to do. Just like it knows it's going to be a great tree. You've got to do what you know works. Okay? Decisions made by people and local people who are mostly directly affected by the approaches that are tailor-made to the local situation on the ground. The work we just did with the discrete and remote communities, they told us this yet again, just like they've told people in all the reviews and the program reviews in the past. But this time it's through a state-based inquiry. You can read that report and you can see that's what they're after. That's what they want. They want local governance. It's about incorporating bottom-down, bottom-up approaches. Incorporating the cultures and the worldviews of Indigenous people. Nothing new there. Been seeing that in the evidence, been hearing that in the evidence. Who learnt that at university? Huh? People putting their hands up. It's what you heard about, right? It's what you do in health promotion. Balance the talking with the doing. Don't just keep having the talk fest over and over again. You know, these bunya trees, I'll come back to these, a lot of lessons for us. Every 3 to 4 years, I used to see all that mob come together, have big yarn up, big feed again. How many of us come back to a conference, have a good food, as my son-in-law would say, Francis went, have a good kai, have a good laugh, watch some dances, have a welcome, not to be disrespectful, have a welcome, maybe have a smoke, dances, have some more talks. But what's the doing? What is the doing? Focus on outcomes. I'll also say that we need to focus on the process with the outcomes. Can't be just driven by the outcomes, because sometimes if we're just driven by outcomes, what happens is we get caught up in a little ticking off compliance mechanism of the outcomes. Yes, yes, yes. But we've achieved things, but really what have we achieved? So I say that the process with the outcomes and about connecting that to real change. Next one's really tricky for government and really tricky sometimes for organisations like the one we're in. Really tricky for some of the big organisations that have a lot of power. Really tricky. Governance and legislative framework that allows sufficient authority to do what has to be done. One of the greatest things that I'm seeing at the moment, and that I've seen with the inquiry, the past one, is the ability of communities to not just have a say and to undertake things, but for non-Indigenous organisations that are basically represent the dominant culture, to go through some changes, to do that work of the governance frameworks and the legislative changes that enable things to happen systematically. That means non-Indigenous organisations have to let go. Start letting go. Non-Indigenous organisations have to be prepared for Indigenous people to sometimes stuff up and make mistakes. I can go up the road and find where UQ is on St Lucia, you know, and I can think, oh, well, maybe the Indooroopilly Bowls Club's someone's gonna rip them off. I can go down here to what used to be Valley Bingo. Someone probably stole off there. I can go to, you know, PNC up here at Wilson, and probably that happened there too. But why is it that non-Indigenous organisations, primarily, you might have a few Aboriginal people hanging out, particularly if it's bingo down the road. You know, I've been known to frequent there myself. But Indigenous organisations aren't allowed. Think about that. Why is it that a shop can exist and run without any government interference, or for that matter, any public health interference? In Camberwell, Birdsville, Baduri, up near the Bunya Mountains, Mount Surprise, Cooktown, but still can't run without government interference in Arakoon, Cowanyama, Mornington Island, or Warrabinda for that matter. Why is it? Why is this state government still involved in selling toothpaste, Kimbies and washing powder? Doesn't happen anywhere else in Australia, right, Mandalay? Nowhere else in Australia. And if we work in public health, we know about that. That needs to happen in terms of governance, legislation, framework and policy that do that to allow people to do what they've got to do. I want to put that on the table because that's an example of what we're trying to deal with that is a broader public health issue. You know, why is it that that still exists? Because they're too afraid them fella not going to have any food. That they're going to be stuffed up and people are going to be left without any food. It's not just about not having toothpaste. But you know, sometimes people got to also be allowed to run their own show. And that's what communities are asking for. I'm very clear about that. Communities want this stuff to happen. And recently in Warrabinda, they kicked out one of the providers who were offering the shop service. And now they've brought in an IGA provider from another town. They're still not allowed to run their own. But hey, they've got another provider, so they're getting there towards there. But you know, I was involved in some of this stuff years ago when I worked with Amanda previously, you know, doing the healthy food basket and looking at what foods were available in shops. And I travel around today, and it's one of the things that hits me the hardest, that from 2002, 2003, we still see this stuff happening in 2019. All these years later, we still see it happening. Anyway, enough on that soapbox, amen. But, you know, we're starting to get differences around pricing, but that's not about what public health's done. We need to have people on the ground advocating for what needs to happen, and that for people to change and make framework changes in legislative framework. Employment of Indigenous workers that improves service provision and accessibility. The amount of fly-in, fly-out workers. I want to hear you, when you're doing your work, advocating for Indigenous people on the ground to get training. When I go around, I want to hear you saying, where are the Indigenous people? Why aren't Aboriginal and Torres Strait people here? Don't settle for second list. Don't keep settling for hearing the same old rhetoric. Don't keep settling for it. I visited communities during these last 2 inquiries, and I can tell you there's nothing like sitting on a plane, seeing, and I took a photo of this because it so disturbed me, and I'm going to use this photo. The whole plane on a Monday morning was full in a fly-in, fly-out into a community, and what that one there sitting there, I'll do the real thing now, she's sitting there like this. She didn't know who I was, reading a book, Investment Australia, buying investment properties, sitting there reading it. Now, don't begrudge her for that, but when I saw her in the community the next day, she said, oh yeah, I use all my remote allowances. I'm only doing this job for 5 years to get all this money so I can buy more investment houses. So I'm not deluded that people aren't there for altruistic reasons. They're there, some of them are in there to get the cash cow. That's what I mean. You need to start talking up. You need to start challenging people and what their motivations are, and then what their motivations are about why Aboriginal and Torres Strait people aren't in there getting the training and doing those jobs. In some cases, non-Indigenous people are too invested in their personal gain to step out of the way. Okay? They are too invested in their own personal gain to step out of the way to allow Aboriginal and Torres Strait people to progress through the system, to gain those jobs, or to get promoted into some of those jobs. That's the truth. Focus on building community governance rather than reporting to senior bureaucrats. Some of the data is purely compliance, and you have to wonder, if some of you here tonight work in government departments and you collect data, what's the data for? How is it cross-matched with other departmental data to actually build change for this community? Because I can tell you the last inquiry, we did a review in those remote and discrete communities of 18 departments, all state and agencies. I see people shaking their head. Louisa, you know, you worked in government. 18 government departments and agencies. Many of them don't even cross-reference their data, but you know what, if they did about certain communities, in particular most of the communities, they would actually see patterns, but no one ever sits and looks at it. And because of privacy, they never actually showcase that with communities. Communities never get their data. Okay? That's one of the big things communities have asked for, is reporting to be done at the local level for their data to come back to them. And you can call it all the fancy names, data sovereignty, whatever, and some academics will probably get some papers out of that. You'll see that coming. Indigenous data sovereignty. But it's Indigenous people on the ground have been asking for that. It's not new. Okay? Not new at all. Ongoing government support, cooperative approaches between Indigenous people and government, including non-profit and private sectors, okay, the non-for-profit organisations. I've got to ask, in terms of the procurement stuff, and I did ask this, and I asked this to the Commonwealth and the state in the last inquiry, how can, and this is documented in our report, community of Cohen, everybody know? Anyone know? 400 people. 87 government and non-government providers. 87. 400 people. Okay? 87 providers. So it's documented in the report. Cross-matched by the economists. Okay? It's not a thing I pulled, it's what was pulled from all the government departments of what goes in there. 87. Who was delivering the respite hack? I think it was Red Cross? No. Mission Australia? No. Press Care? No. Catholic Care? No. Greek Orthodox Church from Melbourne. Nothing about Greek Orthodox Church, right? Because they can apply like anyone else. But you've got to ask how they won the procurement contract from Melbourne to deliver in Cohen. How much money was being used to fly in and fly out? So in terms of procurement, people, if there's anyone here, you've got to start looking at this stuff. Have a start to think about how that affects decisions on the ground around public health. If that's happening in that sphere, how is it happening in other spheres? It's in the report. Just got to go to QPC, discrete and remote communities, and that's one of the evidence we found. That's just one community, many other communities. Cross-sectoral participation in the design of community services. You can call it co-design, you can call it whatever you want, but basically it's about multiple agencies sitting down and having discussions around how things work and could work and be improved. Doesn't happen enough. All of this, people are shaking their head. You know this stuff, right? You know this stuff? Got to implement it. It's about making it happen. Just like the tree knows that this nut knows what it's got to do. You know, ask the question, how does this nut know it will be a great tree? It just does and it doesn't. You know this stuff. So to do this work. Views on what works has come from community views in a range of literature. Ownership of governance improvement. Communities having a sense of owning the process and owning what's happening. Led by Indigenous people using existing community capacity. It's when communities don't have capacity, that's when they say they want some capacity building. We shouldn't be just assuming all communities need capacity, because you know what, I visited some communities where there's huge groups. And you know what, if they didn't have to, like you get that Cohen law, if they didn't have to run after every 3 months, like we were trying to work out, every 3 months, how many status reports were they doing every 3 months or 6 months or 12 months to jump through the next hoop so they didn't get a haven't complied, so they get the next payment. You work about how much their capacity is reduced because they have to keep doing the compliance stuff, and then we come in, I'm saying we collectively now, government, NGOs, universities, and go, hey, these mob don't have capacity, you're going to get some capacity building here. They already got capacity, take the stuff off them. Okay? We saw that over and over and over and over again. Long-term partnerships. We know these bunya nuts produce every 3 to 4 years. Well, hey, sometimes organisations, they're producing a report every year, not every 3 to 4 years. Communities asked with some money that they've had for 30 and 40 years, why aren't they getting a 5-year or 10-year agreement? Why not? What are they really going to achieve in terms of housing in 3 years or a year? Why isn't it a 10-year strategy with funding coming, provided they are reaching the outcomes over that time? Why aren't they? Why aren't with sewerage and immunisation, dengue fever, they haven't got long-term strategies and things that they can measure off over that time, so then they can focus on the other stuff where they just need to put some high energy, instead of once again jumping through the hoops for the short-term things, which we know have to be long-term funded. Building trust and respect, I'm not going to go into that, that's a given. Views on what doesn't work, ones that don't reflect community priorities. I don't know how many times I go look at things and I see and I've just done this review of all this type of research that people want to do, and I go, yeah, yet again, they're focusing on research they want to do as the researchers, or Queensland Health is saying, yeah, let's look at this, when the evidence is there that we know of that already. Or like I said, what has been happening and where the gains made. Why do people yet again need to reaffirm what the gains have been made again? When we know there's areas where gains need to be made and where there's work that is desperate. Okay? Because in some ways, a lot of that work, well not in some ways, I'll be really blunt, a lot of that work is led by non-Indigenous people who have once again a vested interest in what they want to do. What they want to do, not necessarily what Indigenous priorities or Indigenous people may want to have done, want to do, or in fact what the evidence says needs to happen. If we go back to the new public health, once again I'll say, if you're not focusing on the equity and the disparity, you ain't doing new public health. Simple as that. Fragmented or rapidly changing government processes, overload of initiatives, ad hoc funding, poorly coordinated monitored programs and multiple accountability. And I've just said all that about the 3-month hoops, 6-month hoop, 12-month hoop. So getting communities to rush through, do all this work, jump over hoops to meet what? And you know, when I've already said that work is not cross-matched with cross-departments, sometimes even in the same building, from floor to floor, they don't even do it. And it sits in a folder, in a filing cabinet or a compactus, and no one looks at it. No one looks at what happened from year to year. It's just because it's compliance. Yep, there was 15 beds in that hostel. Yep, there was so many meals served. Yep, there were so many immunisations given. Yep. What we did with the Productivity Commission was able to pull some of that and cross-match it. We're doing some of that as well currently with the imprisonment inquiry in different ways. So I can say to you here tonight, 87% of all women who are currently in custodial care in this state either have a mental health issue, currently diagnosed, or some form of social and emotional wellbeing issue, and were more likely to be in care themselves or have their children removed. Fact, never been cross-matched in any data despite the data sets being there. You know, what would some of the things show if we were able to cross-match some of that data that's basically at this time in compliance? So in terms of new work and priorities, think about those things in your work going forward. Good governance, network governance models, not top-down governance models, has to meet the needs of men and women. And I'll say that very clearly. And in some cases also has to meet the needs of men, women and young people and youth and children. But particularly in some communities, needs of men aren't looked at. Women sit around the table, make decisions. In other communities, the needs of women aren't looked at. Men sit around in communities, talk about things with men from the government. Particularly when it depends on who's coming out from government or NGOs to talk with that community as well. It's very clear in our data that that is still happening, despite people saying some things need to be looked at in terms of gender. We're trying to work out recently around some people who wanted a visit from me as a commissioner around imprisonment, and not Commissioner Kim Wood, who's a male, despite it being at a prison that was for men. And we found out it was because there was sister girls there. They wanted to talk to men. So sometimes it's a simple thing, and finding out reasons around why things happen and what needs to happen in terms of that. Dispersed regionalism and bottom-up federalism, and the ways that things work around government, that communities are pushed through to work at the ways things government are doing rather than the ways communities exist. Mutual responsibility, and I'm not talking about this, oh, if you mob do this and get your kids to school, then you can have your petrol tank. Remember that? Remember that one? That was in WA? I'm not talking about that kind of mutual responsibility that comes from the government. I'm talking about agreement of terms that what can happen from community, where community agrees to do certain things in terms of, for their own free will, what they determine is important for them around this stuff. An emphasis on internal relationships and connections. Then I move through the next part. What does work? Any surprises there? Now, I've worked in art shows. I was a CEO of an Aboriginal Medical Centre for a while, Bitchny Aboriginal Medical Centre, give them a plug. I was also worked for Quake, and I also worked for Butcher. And until end of last year, I was on the board of the Central Queensland Aboriginal and Islander Community Control Health Organisation, CQ Rutcher, now transformed into the Centre for Rural and Regional Indigenous Health, combined with the Southwest and Far West. So, in our inquiry with discrete and remote communities, ACCHOs very clearly came out as not just a preferred provider, but doing stuff well in terms of the outcomes. And in this part, I withdrew from some of the work and worked on other things and left the economists to do this. And the economists can show, and through that report and through their other work they're currently doing with imprisonment and in terms of preventative justice, how, and they ask a different question to what I might ask. Some of you might ask this question if you're into the economics of public health. What is the cost of not doing things? So they ask what is the cost of not doing some of the work that ACCHOs do. And it would cost the government a lot more too, in terms of the work they do on the ground. So they push that angle as well as a lot of the outcomes that ACCHOs do. Unintentional racism and barriers to healthcare access, that is without doubt. So the sideline sort of racism that happens in mainstream health providers, that doesn't happen in ACCHOs. I'm not saying it doesn't happen at all, there is some, but it's contained and it's different. Superior performance. This is from the literature, from the research, and from numerous reports. Superior. So why is it that they continually get hard time? Why is it they continually have to justify their mere existence half the time to government? You think about it. Is it still caught in those ideas of, you know, Indigenous people might stuff up? And in that is their racism? Is it caught up in that only non-Indigenous people or the dominant culture can provide it the best? Think about some of those concepts. And play a substantial role in training, and not just training Indigenous people. They play a substantial role in training non-Indigenous people, who then go on and do a whole lot of other things. What needs to happen? This is kind of my last. So what needs to happen to move this, to nurture this beautiful little bunya nut to a tree? What needs to happen for optimal, for this to happen? Adopt what works. I've gone through tonight the things that work, what we know works from the evidence. People need to adopt what works. You need to advocate as public health practitioners in all its shapes and forms what works. Advocate for us, advocate for Aboriginal people out there, advocate for people with the communities you work with. It's not speaking for, advocating in the roles you have. Implement what works. If you have a role in terms of implementing programs, implement what the evidence tells you. Advocate for that. Don't settle for second best. Think about what Elkington would have done. He did not settle, I read about him, he did not settle the second best. He fought for what he thought worked best, and he went for it. And I'm asking you to do the same thing. Embrace what works. Hold that true, you know? Hold that truth and the true part of that for what does work. Keep up to date, but know what works. It's there in the literature, it's there what people continually say. Embrace and hold on to that tightly. Don't let it go, and if you see non-Indigenous people trying to sway you, ask them why. What are they so invested in that they're unprepared to let go of that? I'm giving you permission to do that. Only way this country's going to move forward on Indigenous health is for people to challenge each other in this space. Aboriginal and Torres Strait Islander people, we're 3% of the population. We're not going to do it ourselves. Despite us thinking we might want to, we can't do it all ourselves. Address forms of racism which seeks to resist any of this. And name it as racism, it is. So sometimes it's a form of white possessiveness, what we call in the literature white possessiveness. And you, deadly distinguished professor up here at QT, distinguished Professor Aileen Morton-Robinson writes a lot about this white possessiveness, of the controlling of that for power and the controlling to be maintaining the social order. It's not going to work to change Indigenous health, not going to transform it in ways we need it, not going to bring about disparity changes or address those issues if people keep holding on to the power structures that maintain us in this locked position of ill health. Address issues the dominant culture has with itself about Indigenous people. That's really hard work, I'll acknowledge that. Really hard work. And sometimes it's really comfortable to sit within that because it's just too hard to address it. But I can tell you, if you don't, it's just going to keep coming up. And if you don't, it's going to be there next year and the year after. And you know what? It won't be me standing in this room. It could be one of my grandchildren and your grandchildren listening to a similar address, thinking about and asking the question, why didn't my grandparents, my grandmother, my grandfather, my aunties and uncles do something when they had a chance? They worked in health. Oh, they must have had a tough year, but why didn't they make some changes, considering the evidence is now over 100 years old? All right? Think about that. Follow through beyond the policy and beyond electoral cycles, beyond certain individuals and programs and initiatives. And I will put certain individuals because sometimes we get people within public health who get their little pet projects. And people are nodding, I know you do. I know I have. I've seen it. Oh, my thing is this, my thing is that. I'm interested in that. I like that. Well, you know, they're your interests or their interests. That's not Aboriginal people's interests. It's not going to help us. Work out where they sit with that. Research on priority areas and the gaps, I've said that. And at the end of the day, the big bottom line, need to get on to the job of moving from the will to the willingness. Because I can sit in a room and people will say, oh, you know, they got good intentions. Well, so did the missionaries. They got good intentions. Yeah, well, so did this person. They got good intentions. Yeah, so too did the police. But look what's happening. And look what continues to happen. Unless people have the willingness to bring about change, it's not going to happen. People have to move that will and the intent to the willingness to do and the willingness to make change truly. Okay? In terms of why I put transforming there, originally I thought about transformation. But you know, transformation in a sense has an A-T-I-O-N. Kind of means it's happened. And we can think about those banyas again, you know, the banyana and the shell, and you know, my family goes and gets these and helps give them out to other people. My mum's nearly, 75 going to 80 now, and she still gets my nephews to drive around and get them, and then she gives them to old people, she says, and she's older herself. But, you know, and they will become great trees, some of them, because people try and grow them up and then take them up to the Bunya Mountains or give them to Landcare to do that. Some people cook them, freeze them up now. My family's got some of these frozen for the months ahead, but then we won't have them anymore. But you know, they'll keep going, they're transforming, they keep moving, they keep happening, for they'll be here in years to come. Indigenous health's a bit like that. You know, it constantly needs to be transforming. We haven't got to a transformation of it's done. These trees have been around since, you know, as I said, the dinosaur age. They're still going, they're still living, they're still moving, they're still morphing. We see them in new areas and they move. I want you to think about that in terms of Indigenous health and transforming. It's got to be something that's longer term. It's got to be something that's committed to. The gap's not going to close in our lifetimes. I've sort of now come to that sort of realisation. There's a lot of work to do. We've got to keep the process of transforming. And you know, non-Indigenous people also have to be transforming. Non-Indigenous people got to be transforming in terms of what it means to be on this country, to what it means to have a true welcome from Gudja-Kerry and other people wherever you travel. What that means in 2019 but going forward. Bringing all that together, what does it mean for us as Indigenous people going together in a healthy way? so that we are the forests of the future. We are those long-term, sustainable, continue the future generations in the future. And for me, thinking about the work of Elkington, how are you going to keep going with that work to ensure the sustainability of the future, the people of the future, the health of the future? And you're going to help make, how are you going to help make a tree, a bunya nut grow? I want you to think about that. I'm going to almost leave it there. I want you to take this home because I want you to put it somewhere where you're going to look at it. And it could be in your top drawer at work. It could be on your Duchess at home if you've got one, or your little, cabinet at home. I want you to look at it, and I want you to look at it every now and then. I want you to remember the words that I said tonight. I want you to ask yourself, what are you doing? What are you focusing on? Where are you advocating? Where are you helping around transforming public health? How are you doing it? If I see you around in 3 or 4 years, some of you have seen not for a long time, but if I see you around, I don't want to say, have you eaten a few good meals? And that bunya nut could have, the next lot of bunya nuts are out. I want you to say, what are you doing to help that transforming journey? Thank you.
Well, that was inspiring and powerful presentation and call to action. Has anyone got a few minutes for questions? Do you mind, Ms. Fredericks, if we have a few questions, if anyone's got any? We don't have a microphone, so you're just going to have to put your hand up and speak loud.
Yes.
Thank you so much. That was real G up that I needed.
You did your doing.
Oh, thank you. No, it's just nice to be inspired. You spoke beautifully. I totally agree about non-Indigenous people participating. As a non-Indigenous person, though, it is something that I've struggled with because I kind of feel like, oh, do I belong here? Should I be here? Am I going to stuff it up? Is this not my space? And I suppose I was just wondering if you had any thoughts on how we can best advocate and be an ally and kind of be a support system and not stuff up and do the wrong thing, because I'm from Canada originally, and although the Indigenous cultures are very different, there's that shared experience of colonization, and that's kind of what drew me here in Australia, going, wow, this is, when I moved here, I'm like, we've got the same problems as our meld back at home. This is ridiculous. So I feel comfortable in the space, but at the same time going, oh, I'm still a white chick. How do I help without screwing it up?
I will go to that point that there's a few things. Number one, we're 3% of the population. For people to expect us to fix the whole system ourselves, to have all the knowledge of the system ourselves, to get in there and change the systems ourselves, because non-Indigenous people are too scared of stuffing up, is an unreal expectation on us. And I'm not carrying that anymore. Secondly, if I look at some of the professions, we only have, I don't know, Charles might know, is it 450, 500 Aboriginal, Torres Strait Islander medical doctors? It's one example. To get parity, we need another 3,000. So to think even in some of those professions of people that are making decisions in some of the departments or whatever, who's going to do that if you don't? I would rather people say, like, I'm not sure what I've got to do, I'm willing to work with Aboriginal and Torres Strait Islander people, get people on board to work with, and say, I might stuff up, but I need to be shown and told where I'm stuffing up. I'd rather that, because otherwise that work's not getting done, and it's a cop-out for people not to do it because they're scared of stuffing up. You think I don't get scared of stuffing up? Or other Aboriginal and Torres Strait Islander people don't get scared of stuffing up? You know? But if we backed off every time we got that frightened, we wouldn't do anything either. So you need to think about that. Okay? There are lots of materials you can read about how to be a good ally. There's groups you can join to be about that. It's your responsibility to undertake that, and as it is everybody. So I just say go for it. And talking for is not the same as talking with.
Probably time for one more question, if anyone's got any other questions or comments.
Yes.
I have a question about that time that you've given. Did you say it was from your...
No, it's from that one's from the Ipswich region.
Oh, okay.
Yep. It's from.
Okay. Yeah. Beautiful. Thank you for sharing tonight.
Yeah, they're from Ipswich. Yeah.
I just had some lower level involvement with NDIS. I'm
Yes.
wondering, I'm just imagining that remote areas in particular are struggling to get information and help with their applications.
Some communities more than others, because what's happened is some providers have withdrawn, particularly smaller providers, because it's too hard for them to get registered, which has left some communities almost without, well, not almost, without any providers. And so you can get assessed to have a package, but who's going to deliver it? Who's going to deliver it? Where's that going to happen? So there's huge gaps at the moment. I don't know how that's going to be fixed. Yeah, go
Can
on.
I just make a little, probably it is a question really, Bronwyn, and I'm not sure how you might answer it, but a lot of my work involves particular sorts of reviews or writing up papers for different areas, and one I had to write up, it was a discussion about funerals paper with Queensland churches together, and another one was to do with a group that I do some support work with, the North Queensland Deaths in Custody Watch Group, and both left me with two cases that just will probably stay with me, forever, but it certainly is around this issue of public health and how so important it is to have the different, all I would say all the threads come together to work through this. And so with the Deaths in Custody Watch Group, and I work with them, I still talk with them, not as regularly because I've got more established, but this is the Cairns-based group, and they were working with prison men. And just one case, but amongst many, was they could not get help and medical assistance for an inmate who'd been there for a few years, had developed diabetes, and was really starting, was getting chronic and struggling. And they would have phone calls from him, and they couldn't get him to the hospital to get checked for his medications, and he was getting quite sick, and they were just getting so worried. So they got a call from the prison from him saying, "I'm so sick." So you know what? And they ran through to the head of the prison, couldn't get headway, couldn't get them to listen. So you know what they did? They rang up 000 and said the ambulance there. And only because the ambulance turned up, that they didn't know what to do, so they let him go to the hospital. And so he was able to get some check-ups and things, but not too, within about, it was very sad because within 18 months he had to have an amputation. So within 5 years or 3 years, 3 to 5 years more happened, and then he eventually died. But this is only one scenario of systems that aren't our making that just work against us. And so sometimes having people who do that sort of on-the-ground work is so important and vital to finding those gaps and operating through them. And then the other case, it was to do with Morabinda, and it was just so sad because within 18 months this whole family structure had broken down. A young girl, this family died as a result of a police chase that shouldn't have happened outside on the way out to Woodinda. And 15-year-old died from this consequences of the high-speed police chase. And so 8 months later, 12 months later, when the coroner's inquest report came in, and nothing, of course, was done to discipline. There's no disciplinary action. Cover up, etc., which we see often too within our communities, but within these systems. So you've got this systemic racism and systemic incompetence and flaunting of the system. So this young girl's mother passed away within a couple of months of hearing the findings of that report. And they were already struggling because before the 15-year-old girl died, their foster daughter, who was a niece too, passed away from it, as for quite young, from cancer. So here's the father left alone with dealing with this, and we were trying to talk about how do we support, just to support him with funerals, but the stories that come out, which are so painful and full of suffering, that could be eased with systems coming together. And that is just two scenarios, and one in Cairns in a city and one in a remote area. How do we get those stories to wake up the systems?
The correction stuff has really got a lot of those issues, and even the fact that someone can be in there and in pain, and this is one of the things that we heard. If they go into close down at night, they can be closed for longer than between that and when they get their meds in the morning, longer than 8 hours. So what happens if you're on an 8-hour, 6 to 8 hours with even Panadol? You know, so major issues around that which we've seen. So there's some of the things we're trying to document, and the other part of that is Medicare. People are under a different system of care in the correctional services as opposed to, like ACHOs aren't servicing prisons. You can't ring up and get a GP there because they have a provider under the state system. So there's some of the things we've been documenting in the current inquiry. Some of that's in the draft report, and the team will be looking at that in the final report, which we deliver down to the Deputy Premier on the 1st of August. Look out for that.
Yeah. Thanks.
I think the other thing is when someone dies away from their home community, so if they were in prison or they're in hospital and they die, they're no longer a patient. That's another big issue. So they no longer qualify for the patient transfer scheme. How does a family get their body home? Think about that, because they're no longer a patient.
Yeah.
Simple things, which is really around systems coming together to try and solve and work through solutions to assist community and the system manage that. How does that happen with transfer, and who cares for that person who's now passed away along that journey to go back home? Who receives the body at the end?
We've had one or two well-known community businesses who could do that, often for nothing.
That's right.
Petrol money.
A lot of this is for volunteer. Anyway, I'll leave it there. I know we're getting a hurry on.
Carry on. We continue the conversation.
Thank you.
Yeah.
I think there's still tea and coffee, isn't there?
Yeah. Please join me in thanking Professor Fredericks. And we've got an evaluation form, but I guess the main thing we want to hear on that is, future speakers and what you'd like from us, really. So
we're not so much wanting you to evaluate tonight, but to also tell us what you want in the future. So yeah, thanks very much for coming, everybody. Thank you.
Sorry?